My name is Dr. Richard Martin. I'm an oral and maxillofacial surgeon in North Dallas, and I'd like to thank Dental XP for inviting me to give this lecture today. My contribution to XP is in the form of soft tissue techniques that I use to mold the gingiva around maxillary implants. The fate of the gingival margin on anterior teeth relies on the condition of the buccal plate. And in most instances, no matter what soft tissue techniques are used or atraumatic extraction technique, we will still have resorption of the buccal plate both interproximally and apically. This results in uneven gingival heights and potential aesthetic nightmares. It is well known that anterior dental implants should be placed towards the palate in the maxilla, leaving a gap between the implant interface and the buccal plate. This is done in order to prevent pressure necrosis and resorption of the plate. Whether or not the gap is grafted with bone depends upon the practitioner's choice and associated distance. However, it is well known that soft tissue support of the area is needed. Various bone and soft tissue grafting methods have been used and are well documented in the literature. In my personal experience, I always tend to bone graft the socket and cover with a collagen plug, either an immediately temporize or place a form of transitional interim prosthesis. However, I found that whenever I grafted these areas that there would still be a slight depression of the tissue and volume loss at the free gingival keratinized margin compared to the adjacent tooth. Although acceptable results are achieved and can be achieved, it is with a great deal of effort and at times multiple surgeries. With this in mind, I set out to improve the marginal interface and to maintain or increase the bulk of soft tissue at the free gingival keratinized margin. I started taking keratinized free gingival grafts off the palate based on techniques initially described by Dr. Kobe Landsberg in the mid-90s. He did this by utilizing partial thickness palatal grafts distal to the rugae with either a tissue punch or 15 blade. He preferred the blade and adapted them directly over the socket orifice, suturing to the margin, utilizing the blood supply from the site, instead of using a collar plug or collagen barrier and a suture. I also would attempt to do this with success. However, I still noticed a slight depression at the free gingival keratinized margin, and with that in mind, I set out to, in addition to the socket seal technique described by Dr. Landsberg, the goal was to see could I increase the thickness of that tissue, of that keratinized tissue, maintain that, and prevent further resorption and or increase or bring that more coronally. So today my presentation involves a series of modifications of different grafting techniques that I use to maintain this area. Most of these grafts are from all these grafts are from the palate or from the tuberosity. I've used this technique for the last 4 years and have had very acceptable results. Many practitioners prefer to immediately temporize, immediately load implants. However, I tend to like to use interim prosthesis, i.e. flippers, in controlling the tissue and being able to modify during the healing process. Although this is not favorable to many who believe that it's difficult in controlling the tissue and patient compliance, I feel that I've had success utilizing these flippers and Essex retainers more than any form of interim prosthesis in the maxillary central incisor region. On our list today, we'll look at several things that I go through, the biotype briefly, because in my opinion, no matter what the biotype, we still need a form of soft tissue graft. We'll look at sulcular shaping through the use of transitional partials, immediate or delayed implant placement. What is a papilla presentation on initial findings? And we'll look at the use of lid grafts, i.e. modification of the socket seal, and crepe grafts, transitional partial fabrication, what's our abutment design, and the importance of provisional design. So in this case, we have a very thin biotype. We have movement of the midline frenum, and we evaluate to see if we have adequate bone to place the implant at the same time. In this instance, you see the buccal defect with loss of volume. So we went ahead and placed the implant, and initially I would go ahead and place a connective tissue graft at the same time in addition to a bone graft over top of this. And you see just the different grafting techniques using the molding of using the connective tissue graft and placing it underneath the tissue here. Well, as I stated, I researched the work of Dr. Kobe Landsberg and felt that increasing the keratinized tissue or maintaining the keratinized tissue at the gingival margin was very important and helped to prevent shrinkage of the tissue. So just different methods in doing this, different areas. And this can be done, these techniques can be done for the entire anterior maxilla from canine to canine. However, today I will concentrate on teeth numbers 8 and 9, or the central incisors. So what I did in my modification is what we call a crepe graft, and now see that here, where what I've done is I've harvested a palatal graft, as you can see, palatal to tooth number 9, and I'll basically take this about 1.5 to 2 millimeter partial thickness graft, fold it in half, and place it directly under the free gingival margin, because again, no matter what technique we use, that area is always unsupported and will collapse. So let's look at a few cases, and this first case is external resorption. And when we look at tooth number 8, we see several things: uneven gingival margins, increased width of tooth number 8, as well as if we evaluate the papillas ahead of time, what we can see is the midline papilla is very short, maybe 2 to 3 millimeters, and the papilla between the central and the laterals is also 3 or so millimeters. Now, there have been many studies and many papers talking about being able to maintain papillas between teeth, and I've always felt that it's important to analyze the papilla ahead of time before we talk about the distance between the contact point and the papilla. So here you see we're starting out with a situation of where the actual papilla on our tooth that needs to be extracted is more coronal than the adjacent tooth. Our biotype here is medium to thick. So what we're going to do is go ahead and extract the tooth, and typically in these external resorption cases, this is what we will see, where we'll have a fracture of the tooth at the close to or at the CEJ. However, we'll still have a good root form which maintains that bone and allows us to place the implant at the same time. So in this situation, I've extracted the tooth and I'm performing what I call the crepe graft. You can see nice thick graft that'll go right under that free gingival margin, followed by the lid or socket seal technique. So right at the margin we have a graft and then a graft over top with the blood supply coming from the remnants of the socket. So there was prior to when we placed our implant. You can see the palatal placement with the buccal gap. Again, the graft technique, bulking out the margin, and the crepe and the lid filling in the area. Our entomprosthesis is designed in order to support that tissue. And what I'll go through now is just my technique that we utilize to make these ovate flipper. This is nothing new. It's just simple ovate design in order to help to support that tissue and provide a barrier against our graft. So we take a stone cast and we basically hollow grind it out, fabricate our flipper, and we get this camelback, what I like to call the camelback here, where that ovate helps to support the tissue, and it can be adjusted, taken away from, added to with composite, acrylic, tried material works really well on this. And then here you see what we've done here is we've modified our flipper in a triangular, somewhat triangular form because this tooth was wider mesiodistally than the adjacent tooth. So what I attempt to do here is to graft this, use the flipper to help me mold the tissue, and you can see some of the extrusion of that graft from the socket, and we'll allow that to heal. Typically at about 10 days, you'll see this area where you do have epithelialization of the keratinized margin, and you will get some necrosis of the direct middle portion of this. But again, we let this sit over time, modifying our flipper. We'll look at about 8 to 10 weeks down the road. We'll see a nice bulk at that nice roll and some stippling at the margin. Then we go ahead at about 8 to 10 weeks and take a fixture level impression and fabricate our zirconia abutments here in the anterior. And you can see mesiodistally we still have a good thick tissue fill. And in cases like this, one of the things that we want to be careful of is just how wide is our abutment design, because we do not want to squeeze out the blood supply to our papilla and to our bony interproximal bone in this area. If you bone sound this, as has been advocated by Dr. Salama and Garber, you'll see where we do have a nice level of bone interproximally, probably right at about 2 millimeters below this area. So just a straight-on view. And here's the same case, our provisional. And the reason why I've tilted this is just to show you, if you look at the midline papilla, that we've actually been able to achieve a slightly more coronal midline papilla than in the preoperatively. Now let's look at a non-restorable number 9. And again, here's a situation where we see unequal or uneven gingival heights. Tooth number 9 has been crowned, so it is wider mesiodistally. And are we able to correct this? Look at our papilla. We have a nice long papilla in the midline, but short papillas in the lateral region. So again, traumatic extraction, maintaining the alveolar housing. Go ahead and place our lid and graft. So here again, our flipper is ovate, narrowed down. And again, extrusion of the graft, the soft tissue graft, in an attempt to bring this tissue more coronally. 10 days, you can see that socket sites narrowing. We have adequate bulk. Look at about same photo with the flipper in place. 3 weeks down the road, filling in nicely. 8 weeks. Close up, you can see that's our healing abutment in there. We have stippling of the tissue, keratinized fill. So we'll go back and fabricate our abutment at this time and provisionalize. So here's the day that we put in the provisional, and in the apical left distal corner, we're doing a little modification of the provisional in order to try to get that tissue to drop or move more coronally, utilizing the provisional, which I'll discuss the design a little later in the presentation. So here's our presentation. There's our pre-op and post-op marked improvement. So here we see a thick biotype on this gentleman that was running and fell and fractured the tooth. The palatal aspect goes below the CEJ, so ideal candidate for immediate implant placement, and want to try to maintain that gingival architecture. So implants palatal, buccal gap. Go ahead and harvest our palatal graft, as you can see here. In this case, we are involving a slight amount of the rugae, but we can use a blade and thin this out. So place directly over the socket, sutured in place. Once it's healed, we'll go to our zirconia abutment, again being careful not to squeeze out our papilla. Provisionalization, you see the blanching of the tissue, and done with the design of the provisional in order to get the tissue to move coronally. And again, a technique here that we utilize is called the lollipop technique, popularized and published in PPAD in 2006 by Dr. Brian Lesage from Beverly Hills, by basically contouring the apical portion of the provisional in order to get the tissue to move or migrate coronally.